A very good morning, and thank you for having me here to present two key abstracts of the yesteryear pertaining to loco-regional treatment in breast cancer. I bring my greetings from MGM Cancer Institute, Chennai. So the first abstract was presented in SABCS 2023 by Kelly Metcalf, and it's about surgical treatment of women with breast cancer and BRCA1 pathogenic variant. It was an international analysis of the impact of bilateral mastectomy on survival. So, the objective was to evaluate the risk of contralateral breast cancer as well as breast cancer specific mortality by surgical treatment in women with BRCA1 and non metastatic breast cancer. So, the data collection was done by a medical chart review, and demographic data was collected with patient questionnaires. The eligibility criteria was all stage 1 to stage 3 breast cancers with BRCA1 pathogenic variant, and about 2,482 eligible participants from 26 centers spread across 11 countries. The mean follow-up was about 8.9 years. 852 women underwent breast conservation therapy, 1,141 underwent mastectomy, and 489 underwent bilateral mastectomy. So the results are, of course, they've stratified for less than 40 years and more than 40 years. So about 92 women in the BCT arm developed contralateral breast cancer. 130, that's about 11.4% of women with unilateral mastectomy developed contralateral breast cancer. And it's obvious that in the bilateral mastectomy group, only 4 women developed contralateral breast cancer. And coming to breast cancer mortality, 76 women in the BCT group, 173 in the unilateral mastectomy group, and 36 women in the bilateral mastectomy group died due to breast cancer. So as you see, these are the curves that have been presented. And so for contralateral breast cancer, a total of 11.5% of all participants were diagnosed with contralateral breast cancer, and that's over a mean follow-up of about 9 years. And the overall breast cancer specific survival across all populations was about 82.9%. In the BCT arm, 86.2%. Mastectomy, 78.7%. And in the bilateral mastectomy group, it was 88.7%. The conclusions were women with BRCA1 pathogenic variant and bilateral mastectomy were significantly less likely to develop contralateral breast cancer. And women with BRCA1 pathogenic variant and contralateral breast cancer were twice as likely to die of breast cancer. The hazard ratios were about 2.22. And bilateral mastectomy is not significantly associated with reduction in mortality as compared to BCT. And of course, that implies that unilateral mastectomy had an increase in breast cancer mortality. And the mortality gaps were sustained even at 15 years. So we just have the abstract, we don't have the full text. So that's again a limitation, or we need more information or insight into the actual study. Only the BRCA1 variant cohort was studied. And of course, we need to have a comparative arm, maybe a comparative study between BRCA carriers and non-carriers would be more suitable. And with recent advances in systemic therapy, we need to explore the impact of adjuvant therapy on the mortality. And of course, PARP inhibitors coming a long way may play a role in reducing the incidence of contralateral breast cancer or breast cancer specific mortality. The second article is again, it's different. So it's again contralateral breast cancer risk in patients with breast cancer and a germline. This includes BRCA1 and BRCA2 variants undergoing radiation. So by Mark van Barrel, and the article is interesting because when I read, so till now we don't have any solid article which says that adjuvant radiation for primary breast cancer increases the risk of contralateral breast cancer. So the background is radiation-induced secondary breast cancer may be a concern after RT. especially in women with germline BRCA variants who already have a higher risk of contralateral breast cancer. And of course, the genetic susceptibility increases the radiation side effects and radiation-induced second cancers. So the objective was to investigate whether adjuvant RT for primary breast cancer increases the risk of contralateral breast cancer in patients with BRCA1 and 2 associated breast cancer. And so it was a prospective international BRCA1 and 2 carrier cohort study, and about 5,777 women database was included, including the Hebon from Netherlands. And finally, they excluded a lot of women, that is pre-1990, then where follow-up was not available. And 3,600 women were finally eligible for analysis. And multivariable Cox proportional hazards method were used to investigate the association between RT. And of course, age stratification was less than 40 and the more than 40 groups were also done. And statistical significant tests were two-sided. So out of 3,602 participants, 2297, about 64% of them received adjuvant RT. The median follow-up was 9.6 years. And the RT group had more patients with stage 3 primary breast cancer than the non-RT group. And they received chemotherapy more often. It's 81% versus 70%. And they received endocrine therapy more often, 50 versus 35%. And the RT group had an increased contralateral breast cancer risk compared to the non-RT group with an adjusted hazard ratio of 1.44. And a statistical significance was observed in the germline BRCA2. So again, hazard ratio 1.77. Although in the BRCA1 pathogenic variant carriers, it was not significant. So this was a graph which used the fine and gray competing risk model as a derived contralateral breast cancer cumulative incidence curves, and they have showed that the cumulative incidences at 5-year intervals for both groups, and with RT it is increased. So you can see at 5 years it's 6.1 versus 4.4, at 10 years 10.4 versus 6.9, and at 15 years 12.9 versus 9.1. So Cox proportional hazards model. So in the overall population, RT univariate analysis, the hazard ratio of radiation versus no radiation in the incidence of contralateral breast cancer was 1.35. And by multivariate analysis, it was 1.44. In the BRCA1 group, the hazard ratios was 1.25 and 1.29, whereas in the BRCA2 group, you can see that it is 1.60 by univariate analysis and 1.77 by multivariate analysis. So the strengths of the study is the large population size. Radiation exposure has been stratified by germline BRCA pathogenic variant status and age at primary breast cancer diagnosis. The current evidence from observational clinical studies is inconclusive regarding the role of adjuvant RT and its implication in development of CBC. And contralateral breast cancer may be a result of, as a result of RT exposure, is not a linear curve. So it may increase with time. And some of the chemotherapy regimens and treatments and endocrine therapy may offset the effect or developing contralateral breast cancer. In fact, Druger et al. Noted the rates of contralateral breast cancer increased over time, and of course the rates of contralateral prophylactic mastectomy increased with time, and that resulted in number of patients at risk at 10 and 15-year follow-up analysis being taken off the study because they underwent a subsequent contralateral prophylactic mastectomy. The limitations are, of course, we have a lack of detailed information about the exact RT dose and modality, treatment volumes, and contralateral breast dose. In addition, further evidence of a dose-effect relationship would be the finding that CBCs are more frequent on the medial quadrant or medial side after RT, in accordance with the results of Honing and Stovall et al. And higher uptake of CPM in the non-RT group than in the RT group resulted in earlier censoring of the non-RT group. The conclusions of the authors were RT regimens minimizing contralateral breast dose should be considered in germline BRCA1 and 2 pathogenic variant carriers. Comments? So, the technique of RT has undergone a phenomenal revolution. So, is this study still pertinent in the era of IMRT, IGRT, and proton? Because they have included from 1990 to 2023. And dose delivery. So, does BRCA2 carriers require a different dose modification or delivery based on these study? And of course, there's some literature that is exploring the role of bilateral RT as a risk-reducing strategy in BRCA carriers. And of course, advanced and systemic therapy which may mitigate the risk of contralateral breast cancers. And if at all there's a contralateral breast cancer, does it impact on the survival? And hence the need for future studies and survivals. And the risk of LRR versus the risk of CBC. So LRR on the ipsilateral breast versus contralateral breast cancer needs to be weighed to determine if adjuvant RT can be eliminated in a specific population. Thank you.